I will now put the share screen. This will stop other sharing screen. So yes, you want to continue. So we don't want to look at Dr. Sepa face anymore. So we are going to say yes with this part. And now we can hit this. This is mine, and we say share. Okay. Great. So now let's move to the next part discussion here. So as we know, when we look at patient with uveitis, which is a very broad term, we see cells, we see flare, we see inflammation either in the front part of the eye or in the back part of the eye or in all part of the eye. And it is not always, in fact, it's rare that a patient would come to see us with either the diagnosis already made or one of our colleagues usually already made. In fact, it's the opposite. And as many of us know, often many colleagues may not want to manage patients with uveitis because it does take time. I can easily see, for example, 5 AMD patients in the same time I see 1 uveitis patient. So therefore, it's a mystery for many of us. And so therefore, we need to be able to remain alert as we are looking at our patient. So the concept of masquerade is very important. Certainly, we do not want to miss underlying things. And the more you practice medicine, the more you will learn that you know very little. And so we do make mistakes at times because we don't look carefully or we forgot to look carefully. So I'm using now this lecture to emphasize a very important aspect that we don't want to miss. And in this particular case is a situation with intraocular lymphoma as a typical way. But this approach that we talk in this presentation will also be applied, let's say, if you were to miss an underlying infection, for example. So as the way of disclosure, our university received research funding from various sources I listed here. I myself chair various studies that
Dr. Nguyen?
Yes.
You're on presenter mode right now. If on the top bar you can see display settings, you can it's on the left side of you. You can change that to swap presenter view. Yeah.
That's good. Okay.
Yeah.
That's
they're perfect. Thank you.
Perfect. So now let's move on. So these are some of the questions that you look to. Hopefully you will be able to get the information here. So one of the questions that this presentation helped to address is that what to do and what to look for. So one of these questions would be, which of the following interleukin level is often elevated in the vitreous of eyes with intraocular lymphoma? Is it interleukin 6, 1 beta, 10, 17, or 8? So you have those choices, and hopefully by the end of the talk, you will be able to get this answer. Next question is, what does intraocular lymphoma look like? Cell and plum or sheet of cell, multiple yellow-white lesion at the retinal epithelium, this swelling, any of the above, or none of the above. Okay, so let's start with this case, which is a case that I learned and still remember from the fellowship here. So the patient was a 69 years old white Caucasian female who developed bilateral posterior uveitis in January 1995. Again, the term bilateral posterior uveitis is because of the little bit non-specific, but basically we see inflammation, we see cells, and so on. No previous, no medical history, and the chief complaint here is floater. Now, if you ask any of us who define what floater can consist of, it can be anything from a posterior vitreous detachment to vitreous hemorrhage to vitreous cells, multiple things going on. There was some anterior uveitis. The patient has been treated with topical steroid and regional steroid injection. In April 1996, she was referred to the retina service as a tertiary care center, after which they see cell, 2 minutes cell, both the front and the back part. So they say, forget it, we don't have time, we'd rather just look at the macular lesion. So they then referred it to the uveitis service with that. At that time, the visual acuity was 20/25 in the right, 20/70 in the left. And just segments show a few kPs, character precipitates in there, and just a very small amount of cell in the anterior chamber. So 0.5 plus cell, therefore less than that cell that we can count. The vitreous was described as having 2 blood cells when we saw the patient and 3 blood cells on the left. So 2 blood cells on the right and 3 blood cells on the left. And that Dr. Seppa has discussed with you. These are some of the grading that in the past has been published and recently mostly been finalized by the Sun Group. And this is the fundus of the photo here. So let me see here. We have Natasha here. So Natasha, describe to me what you see and what are the things that you can consider beside lymphoma here, because my talk is on lymphoma, so we don't want just to talk about lymphoma. If you look at the eye with this type of thing, what are you seeing and what thinking are you having here for this patient?
So there is vitreous haze, and there might be what's referred to as snowballs or snowbanks, unless there are retinal lesions. It's a little hard to tell. Could be intermediate uveitis, parsplenitis, could be infectious, could be candida, could be lymphoma.
Excellent. So Natasha is one of our second-year ophthalmology residents right now at Bayer Stanford, and we're very proud to have her. And obviously, she's to be quite voice of this. So this is exactly what you should think of, exactly what Natasha described. What we see in front of us is a clump of cell in here, and it's whitish, so definitely you can describe it as a snowball, for example, in this aspect from here. And the view is a little bit hazy, one because it's the vitreous is hazy, but two, because in order to take this photograph before the era of wide-angle photography, one has to bend the eye a little bit. So therefore, the view is not great, but this patient is hazy. So that's what you see in there. Now, this is the lesion now that may help. So Natasha just described to us, for example, the vitreous, the clump that we see. Now, Bryce, what do you see now, Bryce?
So I see some, looks like multifocal diffuse whitening below, or I guess below the level of the retina, so possibly in the RP or the choroid.
Yes, so that's excellent. That's quite well. Bryce is another one of our second-year residents. So for this aspect here, right now, what we see is that first, Bryce described as subretinal because we can see the vessel growing to it. So that is correct. You see this whitish lesion. Bryce used the term multifocal. So let's clarify that bit too. Yes, indeed, we see that it appears more than one place and maybe stretched, but this is a subretinal type of lesion. Multifocal in the field of uveitis usually describe a little bit more discrete lesions and type, so certainly can be considered, but when you say multifocal, usually it's had to be a little bit more discrete in here. This is more of a non-defined or not so well-defined subretinal lesion here. So now, if you just saw the patient, if you just saw the image that we showed the slide before that Natasha described, that's just vitreous ball and vitreous and clumps that we see. Now over here, we see that and we see this lesion. So now it shifts our thinking a little bit more. So if intermediate uveitis would consider in the initial cases, now with this finding, it shift our thinking because intermediate uveitis usually does not present with this type of lesion. So as you can tell the thinking here, when we first see the vitreous clump, vitreous ball, we think of one way. Now with this additional information, we then move forward to think of an additional aspect from here to this aspect. So we can see that now our thinking shift a little bit. Same, again, every piece of finding will help, and that's what we like to consider and using that. So information is there. So it's very helpful. And when you see a lesion like this, Hasham, what are you thinking of in the lesion? Let's say you see some subretinal thing lesion like this. Hasham, what kind of thing did you see beside lymphoma, which is the topic of our talk? So Hasham, I have a little bit difficulty connecting from Egypt, but what we're seeing in here is that when you see some subretinal lesion like this, oftentimes you can also consider either an infiltrative process of some way that now has infiltrated into the retina and the layer beneath the retina. Hasham, can you talk now?
Yes, I think so.
Okay, so in addition to lymphoma, what type of thing can you consider?
So I would think about infective causes like fungal or viral retinitis.
Okay, so certainly process like this, so infectious process is certainly under differential diagnosis as well with this, especially when the vitreous is healthy. So as you can see, the finding, yes, we have to know what our discussion is about, but when you see this in isolation, depending on what other clinical data, you will be able to consider under differential diagnosis of different things. For example, this type of lesion like this, could the lesion be a fungal infection, for example? The answer is yes, that type of thing. So that you use the various data point, you use the various finding to make the diagnosis. Okay, so let's move on. Prior to coming to our infirmary, when we saw this patient, they have had some other investigation already. They have a CBC, which is chemistry, testing for syphilis, testing for sarcoid, chest X-ray to rule out TB, to our sarcoid, ANA, which we will discuss a little bit later, the urinalysis, skin test, different type of thing, and all of which has been negative or non-revealing at this type of thing. So at this moment, what should we do at this moment to be able to move forward here? Luciano?
Sorry, so I mean, you can consider additional imaging, maybe get fundus autofluorescence, FA.
Okay, so you just say additional imaging, which is certainly possible. So for example, autofluorescence you mentioned, is autofluorescence the best way to evaluate the patient at this time?
I mean, probably it won't give you a definitive answer, but you can continue to gather data. I think FA might be more useful. So
autofluorescence, in order for us to use AF, usually it should be a well-defined lesion, because various studies, including our and others, have shown that we usually use the difference between the border of the lesion versus the other outside border in an effort to see whether or not it's hyper or hypo to tell whether there's activity. Since this patient so far, we don't have very well-defined lesion, that may not be so helpful with this aspect. Fluorescein angiography is certainly possible, but what if I were to do FA in this patient, what am I looking for?
So, I mean, you might be able to see some blockage of autofluorescence from blockage by tumor cells, and I guess you could see some, maybe some leakage as well.
So if you say this blockage from the tumor cell, that's certainly
if you actually had, defined lesions. I don't know, Natasha mentioned the snowballs versus retinal lesions at the beginning.
Correct. So if you were to think of the initial picture when Natasha described when you see snowball, a fluorescein angiography in this case would, if it showed, let's say, perivascular leakage in the periphery, that may go well with the diagnosis of intermediate uveitis with the presence of the snowball, snow clumps, and the perivascular leakage, which is very appropriate in that case if we want to see that. The patient also has been shown in the last picture to have some retinal lesion, a subretinal lesion part as well. That may make it a little bit less. So if we were to do a fluorescein here, we will look for, in general, perivascular leakage. There will be certain type of tumor that will block and will basically cause a thrombosis stage in which you will see blockage. Lymphoma is not likely to be one of those, but other, for example, leukemia will be. So that's very appropriate you say we were to do that. Okay, so then that would be some diagnostic step. What else can you consider here, Luciano?
Maybe you could do a diagnostic vitrectomy.
Okay, if you do a diagnostic vitrectomy, then what would you be looking for?
I assume you would send the cells for flow.
Okay, that's important because obviously we want to look at what is the composition of the vitreous, right? So that is important in this aspect from there. So yes, so we will go ahead and proceed. And so in this case, the diagnostic vitrectomy was quite important because we feel that at the time of this, given the presentation, we think that given the clumps of cell in the postplanar, given the subtle or somewhat non-discrete subretinal lesion, that's what I'm thinking, and that's what we worry about, are concerned in this aspect here. So we move forward to do a diagnostic vitrectomy, and in this case, unfortunately, this is what we find. And so the cytology show in here the atypical lymphocytes, which is quite suspicious for malignant cell, and that's something we definitely do not want to be able to see in any vitreous, because that obviously is a sign of concerns with this aspect here. So here, what else can we expect to see from the vitreous? In other words, what other thing can we study from the vitreous here? Okay, so here is one of our fellow from Vietnam, and so this is the aspect that we see. So in addition to the cell that we're looking at, we also can look at the various interleukin level. And so now, why would he want to look at that in this aspect from there? In other words, what exactly is he expecting to see from this, Connie?
So you're trying to diagnose what lymphoma, if it is lymphoma, and also I think you can get some prognostic information from those studies.
So if you were to expect now, given the cytology, what information from the interleukin that would support a diagnosis from of lymphoma, what type of calculation or what type of measurement would you expect to see, let's say in terms of interleukin?
So you'd have an elevation of interleukin 10, and you'd also want to look at the ratio of interleukin 10 and interleukin 6.
Perfect. So this is another type of thing that we see, and in this, for this patient here, this is what we saw. Very unfortunately, so consistent. So her interleukin 10, Connie has suspected, is about 8 times that of interleukin 6. And so the ratio of 10 to 6 is definitely greater than 1 here. So this is very important in this aspect here from there. So interleukin is something that's really important. Now, what else can we learn? Dr. Michael Mack, what else can you do with the vitreous?
So you can also send it off for PCR. There are other cell markers like identifying the cell type. So CD20, CD3, I think, are the ones that I remember. And then that may help with the oncologist with the cell typing.
Yes, so again, when you take a patient to do a diagnostic vitrectomy, you want to maximize your potential of getting odd information from it. So yes, if we suspect that, like this patient, for example, any patient, if you're thinking of intraocular lymphoma, then you will look for IL-10 and IL-6 at, Connie was saying, you can also look for other marker at Michael Mack from Canada just mentioned, to look for other type of things. But remember, do not also forget that we still have to worry about other potential causes. For example, infection, if the clinical findings suggest that. So this would be a great time also to do a full microbiological workup. So in other words, you look for gram positivity or negativity, culture. You also want to look for PCR of some common infection. For example, in the right population, this is where you also ask for PCR for, let's say, cytomegalovirus or the HSV or VCV, any of those things that will be able to help us to identify that. Yes, we never got to this case, but in general, I want to make sure that this concept is being understood by everyone, that when you do this, you want to learn as much as possible because the sample are very precious. So you want to take that and you want to study it for it as much as you can. And therefore, in addition to what we say, make sure you don't forget for example, the microbiological workup for this patient. So in this patient, as Michael was alluding to, we also did the PCR for IgG gene rearrangement, which is another way to diagnose intraocular lymphoma as well. So in this case, it was positive for monoclonal cell population, which is something that you request for, and this is definitely that will help us. So therefore, our particular patient here, unfortunately, had evidences that very suggestive of intraocular B-cell lymphoma, and it's a high risk for different CNS lymphoma, which is something that we as ophthalmologists can help to save the patient life. So in my career so far, I have seen this in probably about 7 to 8% of the time when a patient would come in that this is our clinic that will have this type of concern that did not come yet with the diagnosis of CNS lymphoma. So in that percentage of them, it is when we as ophthalmologists make the diagnosis of lymphoma and then definitely activate the whole medical team that includes oncologists or other aspects as well, because we now then know that patient with intraocular lymphoma will very likely develop CNS lymphoma. So that's our concern of that. So we make a diagnosis of CNS and intraocular large cell lymphoma for this aspect for this patient. It's a very unfortunate diagnosis, but at least we make, and we would like to get obviously be active as soon as possible to be able to control the disease. So in this case, we recommend, and this is when I was in Boston, so we recommend that the patient get high dose of intravenous methotrexate at Mass General do that, because we know that that time we know that patients who have intraocular lymphoma are at very high risk for developing CNS lymphoma with this aspect from there. So in this case, some people who may not be familiar with the field may think that this is too aggressive to go for systemic, but the data definitely have shown that we should consider the whole patient when we treat this patient. Unfortunately for this patient, she, because of the different location, preferred to be treated locally. And so the local team decided to treat the patient with radiation therapy only, and also only to the eye aspect from that rather than to, because the idea was that they thought it was mainly a local in the eye. And so they just wanted to treat the eye only. So in October 1996, a year or so afterward, the patient was described as cured because we no longer see the cell. The visual acuity stabilized and improved to 20/30 OD and 20/40 OS. And indeed, the cells in the eye has improved quite a bit. And we now get a very nice clear view of this aspect from there that, that we don't see it before. So this is definitely showing improvement for this aspect from here. So at this time, do we need to worry about anything at this moment? Natasha, is the patient out of danger?
Well, did she have the workup for CNS lymphoma already?
That's correct. And there was nothing at that time to show anything on the brain.
I suppose they can recur.
Recur where? This is the right eye, and this is the left eye. So both of the eyes seem to be doing better. Okay, they radiate the eye, and both eyes do well with this aspect. However, one of the concerns we have, and now this is the teaching that we like to share with everyone, is that patients with intraocular lymphoma can most often, I would even go as Sean said, never be treated just by local therapy only. And this is the reason. The reason is because this patient, one, is to extend into the brain, or two, will relapse in this aspect. So you have to think of treating it in a cross perspective out, just like the whole concept of treating uveitis, which is topical steroid when it's a posterior segment disease and symptomatic disease, and expect that local therapy to work all the time. It does not work. So same thing with this aspect from here. When a patient in particular has intraocular lymphoma, one needs to be very, very concerned about that it will be spread to the brain is one, and second, it will relapse. And so this is the reason why I repeat it again, that we are very, very key in certain type of patient to help to make the diagnosis, because we definitely can help to save the patient eye, and not only that, but own patient life as well. So here, as you can see, this is the right eye, and this is the left eye after radiation therapy to the eye. It did work, and it worked quite well with this aspect is help. But unfortunately, when we treat this, and we have to be really strong, we as ophthalmologists, when we discuss this type of cases with our colleagues in oncology, for example, to make sure that the patient is treated properly. And in most centers, the oncologists in this era should now recognize that treatment of intraocular lymphoma cannot just be with the local therapy only. When I mean local, I don't just mean thing that we give to the eye by medication, but things like even like this patient who actually had radiation to the eye and still relapsed. So then she relapsed in 1997 with CNS and intraocular lymphoma. The vision in the left eye has now dropped, and it's dropped because of this finding in here. Okay, so now as you can see, so how much vitreous haze do we see here now?
4+.
4+, exactly. So Dr. Sepp, I just mentioned you, now you can barely see the optic nerve, which is the left eye here. You barely can see that aspect. So this is definitely the haze that was there few hours, you can barely see it out. Okay, in this aspect from here. So Bryce, in a patient with lymphoma, Bryce, when we see a recurrence, and obviously we see vitreous inflammation right now like this, what other part or where else in the eye can we see the recurrence of the lymphoma?
Would we be also looking in the anterior chamber?
Okay, and if you say the anterior chamber, what are you expecting to see there?
See if there is any cells in the anterior chamber.
And if you see cell, what type of cell are you seeing? I'm asking about the morphological description of those cells.
I guess tiny white cells.
Tiny white cell. Connie, tiny white cell?
I think you may have spillover into the anterior chamber. I just don't remember off the top of my head if you'd see like a pseudohypopion.
Yes, so it's very important that we see. So the cells are actually big, clumpy. They can form a hypopion. They can form a hypopion, and if that's the case, they're very large cell and the good soup is there. So as Price mentioned, you can see the recurrence of the cell or the appearance for it even in the anterior chamber, where you see a lot of cell and they're big cells. So even with this, at the state them, it's very impressive because you can see them, and you can also see them lay a different aspect. And in this case, this patient have cell in here, this in this aspect, and so you will be able to see, and sometimes because of the blockage of a lot of the cell there, you may see some neovascularization of the iris as well. So yes, so when lymphoma recur, you can also expect, in addition to vitreous cells, you can expect that it also appear in the anterior chamber as well. Not every case, but at often time at those cases you do. And if you ever see an hypopion with from lymphoma, take a look carefully at those cells, because those cells are much, much larger than, let's say, a cell that you see in B27 associated uveitis, for example. So the cell over there, you see hypopion, but they're much, much more smaller. Lymphomatous cells are very large, and in a way that's quite juicy and large there, and they form a hypopion in there and very big, in that case. But the concept here is that the anterior chamber can be involved as well, and once it's involved, it can cause a problem. And then when there's so much cell in there, the intraocular pressure may increase. Then you may get secondary glaucoma or ocular hypertension from it as well. Okay, so be on the lookout for both the inflammation that we could in the back of the eyes as well as in the front part of the eye as well when you do that. Okay, so in this patient,
Nguyen,
yes, go ahead.
sorry to clarify. So you're saying this can happen with recurrence, but can this presentation also be present with
Initially,
primary
yes,
initially?
so that's a very good point. I'm glad you mentioned, because I was mentioning that, yes, it can present initially, although it's much, much rarer that you see. I think I only seen like maybe 2 cases in my career where it's just the cell alone. Or the other aspect is that, so I had a case where the recurrent relapse of it, I did not actually see much cell in the posterior segment, because we can dilate the pupil, you can choose to that, but the cell were much more in the front part of the eye. And I obviously was very curious, so I wanted to prove myself. So I actually took out some of those cells from the AC, and indeed there were malignant cells. So your point is correct. That is definitely can occur with just the AC cell only as the first manifestation, although it's much more rarer than just have the other one. Okay. So this patient that relapsed in the brain, visual cue drop at that time. So at this time now, the team decide, okay, so not only would you now have to do the whole brain radiation, you also have to now institute chemical therapy or chemotherapy as well. So in this case, the patient was given high-dose intravenous methotrexate with this aspect from there. So this is the course that the patient had gone through with this aspect from there. And what do you think the prognosis of someone who has a worsening of the disease and have the reactivation of the cell and now being treated the second time? What would be the prognosis of this patient versus a patient with whom we treat completely initially? As you can see from the way I asked the question, so the prognosis in general for the patient, first of all, the prognosis of lymphoma, unfortunately, when the CNS is involved, is not very high with this aspect, especially when you consider long-term relapse and so on. But definitely those who were not treated properly initially tend to have a worse prognosis. We do not have thousands of cases of this that we can do, for example, a randomized control trial to say if a patient have intraocular lymphoma, should we randomize them to local therapy, radiation, but not to the eye only, versus local versus in combination with brain. Because as you can imagine, just a study would not be ethically possible nowadays, given what we know. So it would be impossible to do just a study. But from our experience, if you have lymphoma in the eye and you treat both the eye and the brain at the same time, they tend to do better in terms of overall prognosis compared to if you just were to treat with the eye only, whether to radiation and or with local therapy in this aspect from there. So that is the reason why all of us who are in this field are always so concerned with this aspect that we don't want to miss. And for all of you who are going into ophthalmology and get board certified from it, you can be certain that some way, some form of this question will be asked during the oral board, because it's a very key important concept that none of us want to miss here. So we definitely want that to be able to get through with this. So unfortunately, in this patient with this aspect, the patient died of CNS lymphoma with this aspect from there. One can argue, well, the patient may have this course no matter what, and that may be true, but definitely the fact that it was delayed certainly contribute to this aspect from here. So it's a case that have a very sad, unpleasant blending. And this is one of the few times in our career in ophthalmology where we witnessed our patient die that thing that related to the eye disease and overall disease, but it's also a very clear lesson to us that we cannot miss this type of thing, or we try our best not to miss this type of disease, and we need treatment to be as fast as possible and as positive as possible in an effort for us to control the disease and the patient life as well. So one of the things that we consider to be very important in this aspect from here is that the sampling of the disease. And this now I'm going to a more general concept. When we treat uveitis and ocular inflammatory disease, one needs to be quite alert and be aware. If you suspect that the diagnosis is X and therefore you give treatment Y, you should expect the disease X to respond. Maybe not immediately, but definitely should get better with the treatment Y if treatment Y is proper for disease X. When you notice that you do not get complete response, or you don't see any response at all, or you've seen that the patient get really good, then you need to stop and get specimen and get biopsy. That is a very key concept in managing patients with uveitis. Do not let the disease linger on months after months, let's say on steroid or on whatever you give it, and the disease keep not responding or not showing complete. So doing a biopsy is very important. That's why if you keep that in mind, you will be very successful in management uveitis. So in uveitis, when we don't have a good response, or we don't have expected response, we should do biopsy, whether do a biopsy of the anterior chamber, do biopsy of the iris, do biopsy of the conjunctiva, biopsy of the sclera, or of the vitreous, or of the retina for that matter, of this aspect from there. So the vitreous biopsy is very important, and oftentimes we practice on a regular basis like this. When we don't get a good answer, it's very much that we want to get the vitreous biopsy. We don't want to linger on. And another concept that may become a little bit later is that when you don't know what's going on, do not inject things into the eye. Definitely do not inject anything. Unless you're absolutely clear with things, don't do any type of injection into the eye, especially with steroid, unless you have a very good understanding of what it is. So the vitreous biopsy is important in here. And so therefore, you want to make sure you get as much of the undiluted sample and you as much as you can, because you know the cytology lab or the flow cytometry or the microbiology, they always want us to send a lot of fluid. They forget how much we can get from the eye. They always say, this is so little of thing for you to do things. So you want to try your best to get as much fluid that you can from the eye in this aspect from there. And when you do the vitrectomy, you want to do not just a core, but you want to do a total vitrectomy so that you can get material from the all area that is harvested, including, let's say if you have lesion that right on the surface of the eye, then your assistant can help you to depress so that you can use your cutter to come as close to that as possible without cutting the retina, obviously. And so the other thing is that when you do this, you should plan ahead of time. This type of diagnostic procedure should not be performed, for example, late at night, for example, because you don't have a way to deliver the specimen. And you don't want to do it on a Friday night or Saturday either, because the lab may not be able to process those specimens. And those specimens are very precious. So you want them to be delivered to the right place with the processing at the right time. So before you do this, you need to arrange for that. So either you at the attending or your fellow, one of you should take this directly to the lab yourself when you do this. Or if you have another system where one of the nurses can take it to the lab immediately, because you don't want to have the specimen lay around. So that's why it's very important. We do it here because we really want to learn something from the vitreous, and therefore we have to take the time and do it well and deliver to the right place. So we've been alluded for, so when we get a vitreous biopsy and this aspect from there, which we usually try to get back, we send it to, in this particular case, to the cytology, because it's very important to be able to see what type of cell that is. And so the ocular pathologist will be wonderful. If not, expert cytologist who will be able to tell what type of cell that's present in the eye. That is very critical. Flow cytometry will also be beneficial because if that is the, can tell you how much of the cell is present and so on with that. As we mentioned, we look for interleukin 6, we look for interleukin 10, and with that, and I also mentioned the IJ gene rearrangement by PCR as well. The other thing that I did not mention is that there's MYD88 mutation analysis. That is another testing that you can, that you not just can, you should do in the case of like this by PCR that will help you to be able to tell whether or not there is inflammation there and there's a presence of this mutation to help to support. So on a way like this, make sure that you check for cytology, you ask for flow cytometry, you ask for the interleukin-6, interleukin-10, you ask for rearrangement, and you ask for the MYD-ADA. This obviously we cannot still 100% rule out, but a lot of the time with this testing, it can help you a lot. And of course, as I mentioned before, in a different case, make sure you also send your vitreous biopsy, your vitreous sample or the vitreous washing in there to microbiology as well, so that you make sure that you get this test for the appropriate places from there in this aspect. So now, let me ask you, so Luciano, let's back to you. What type of patient demographically present to you with intraocular lymphoma? Or when do you begin to get suspicious for that?
I mean, I would guess probably sort of older patients in their 50s and 60s.
Okay, so now people who are under the age of 50 consider older. Okay, so I'm beginning to go into the category now. So that's kind of sad now, but that's fine. Okay, so the age of 50 to 60, like that, of this aspect from there. Okay, Hashem, do you have anything to add to the age distribution?
So I'm not sure, but I think that there's another spike in earlier ages. I think like teens or 20s.
Okay, so this is very important to know. So in general, Luciana is correct that usually we think a patient over the age of 50 is a similar type of condition of this aspect from there, that they may be at slightly higher risk for having this. That will be concerned, just like some other uveitic entity that we will discuss later, that age group like that. But we have to be very, very careful about this, because the age in this group range very broadly. So the age has been reported in the literature has gone anywhere between 15 to 90, with the mean age about 65. So this is absolutely correct, because just in my 3 years at Stanford so far, we have had 2 cases where the patient were in the mid-30s and the other one was early 40 when intraocular lymphoma was diagnosed. So clearly, we should not just be biased and use it only in, or consider only in patients who are elderly in that, because this can occur in young patients. That is absolutely correct and true. It is appropriate, yes, that they're more likely to see more elderly patients, but we still cannot ignore them in the younger group of patients, because they do exist. And if you don't consider, you will miss it. Okay, so the other aspect is that oftentimes, 75% of the time, it would be a bilateral disease, this aspect. So it's very rare, that it's rarer, that you just see is only in the one eye and not the other eye. The other things about it should be on, let's say, if someone to ask you to give a differential diagnosis of painless decrease in vision. So this is one of those. Another thing would be completely different. For example, when you have central retinal vein occlusion, that will be painless decrease in vision, or central retinal artery occlusion, that will be painless decrease in vision. Obviously, completely different type of disease, but in this case, lymphoma or malignancy will also be a type where you have painless decrease in vision as well. This aspect. The eye, unless was asked by Connie, that unless the entire segment is involved, the eye can look quiet. There's no conjunctival injection. There's no anterior chamber cell, for example. Most of it can put in the back of the eye unless both chambers are involved. And so it oftentimes have a delayed diagnosis from this aspect, because yes, people and colleagues may think of it, but they may or may not take the time to really handle it in the proper way. For example, I am talking about particularly doing vitrectomy. Many of us will be able to do vitrectomy, but that's not where the challenge is. The challenge is what happened to the specimen after you get it. Have you done enough of the preparation to make sure that those specimens are being sent to the appropriate places? That's where the most important part is. it is not just doing the procedure, but make sure that the specimen get to the right place. So the preparation for this procedure is extremely important, whether it's go to the microbiology lab or go to the cytology lab or to whatnot. You have to make sure that they're in there. And so you time yourself to make sure you don't do that in the inappropriate time. And of course, all of us, we try our best. We are in medicine, so we want to make sure that we save patient life. And so anything that would decrease the high mortality rate would be very helpful for this aspect from there. Okay, so for intraocular lymphoma, certainly the treatment we alluded to will require that using a systemic combinations of chemotherapy, in which case we use either systemic rituximab and methotrexate, plus at the same time intravitreal rituximab and or methotrexate. So what do I mean by that? All of my patients with intraocular lymphoma are also co-managed by the neuro-oncologist as well. So they will see the patient. Every day call, they say, Kwan, we begin to see some recurrence on the MRI right now. So obviously, when I see that patient, I'm extremely sensitive and look extremely carefully for the presence of any cell or recurrent cells, either in the anterior chamber or in the posterior chamber. If I don't see anything, then it's fine. I let the oncologist know. I say, we see zero evidence right now, ocular cell that we can see. But you see that it would be important for you to treat. Now, I'm going to just deviate here a little bit. When I say we don't see anything in the eye, I meant on the cell, but also on imaging. Dr. Seba have done a study which he did not present, is that when we look at the OCT of patient with intraocular lymphoma, we notice the change and notice the presence of this hyperreflectivity in the RPE level on the cell there that occur regardless of whether we see cell or not. So when I say I don't see anything in the eye, I do not just mean that looking at only at the presence of the cell, but I also talked about whether or not I see any change in OCT. Basically, the complete ophthalmic examination and ancillary testing. So that's what I meant, because that the study that we have done and now we continue at Stanford to look for that is that there are changes on OCT that occur that may occur before you notice any type of cell, for example, in the eye. So that's very important. So even if I don't see vitreous cell recur, but yet I see changes on OCT, I will still tell the oncologist that we have to go ahead and treat because of this. So in that case, they will go ahead and continue with the chemotherapy. We will continue with the intravitreal rituximab and or methotrexate. And oftentimes when they have recurrence of this, I usually use a combination of rituximab and methotrexate. And as a trick, when you do both injection, make sure you do AC tap ahead of time because the pressure will be high. Since both of these require 0.1, 0.1, so 0.2 ml of injection into the eye. So you need to do a paracentesis beforehand or shortly after, but usually before is easier so that the intraocular pressure will not be so high on this. Okay, so does anyone else know other type of treatment beside what we just talked about here, chemotherapy? What are some other type of treatment that we use for lymphoma? I mean the whole medical community, not just ophthalmologists, but oncologists too. So what other type of treatment do we use? Connie, do you know?
So I know we can do like local radiation.
Mm-hmm. What else? So what we can also consider would be bone marrow ablation as well as the stem cell graft. So stem cell treatment has been in there as well. Stem cells usually reserved for cases that fail other, but definitely they can be considered even a primary treatment as well, depending on extension. So the reason why we know about this is because it's not that we need to perform them because it's outside our field, but one need to know this if you manage patients so that you can communicate intelligently with the oncologist so that when they discuss about this, you would agree that not and so on. If they want to propose to you that we should do stem cell right of first-line therapy, there must be a reason because the disease is quite advanced state and they want to get a bed shot, for example, so that's what they do from that. Okay, but those are the treatments in there. So local radiation, like Connie say, some of the systemic chemo, and then the stem cell graft is another aspect from there. So The diagnosis of intraocular lymphoma is very important because when you look at the eye, it's different. The type of cell that we see in there is different. So in the vitreous, when you look at the slit lamp using your 90 or superfield, whatnot, you will see the cell. And in my experience, it's oftentimes that it's not just localized, isolated cell, but rather that you see a sheet of cell. That is something that in my experience, when you see this, you definitely need to be concerned about this. It's not 100%, but oftentimes when you see this, you want to make sure that you have a diagnostic vitrectomy plan for that. You can also see, in addition to cell and plum, you can also see edema of the optic nerve. You can also see the yellow-white lesion that was seen noticed before when Natasha pointed out to you, and that's aspect and Price pointed out to you also to the yellow-white lesion at the RPE. And certainly with the CT and MRI and lumbar puncture, you can also expect to see that. So this is what we cover. And of course, then we do the diagnostic vitrectomy with this aspect from here. So when you do a diagnostic vitrectomy on this port, it's a standard 3-port vitrectomy that we do, and this aspect from there. And so in the past, in general, you have done, may have seen this, the eye, we cannot remove from the vitreous, which only have maybe about 5 cc or so, you cannot remove much of that, because otherwise the eye would collapse, right? And when you want to do this, you want to get the undiluted specimen, because you want the pure specimen. So you have to do this before any of the bilateral solution go into DSF, go into the eye. So you want to do it with the eye just purely not touch it. So because of that, it's not easy, but we try our best to get a certain amount of the undiluted specimens, and then to send for flow and to send for cytology, because you want the best chance to get that. And then the diluted specimen, usually, which is what is in the cassettes in there, that is where we send it to. That is where we send it to the microbiology to do the initial testing in there, aspect from there. And so we want to do, as we mentioned before, we want to do a very complete vitrectomy on this aspect so that you can get as much as possible. And if you see things on the surface of retina, we carefully try to get that as well in this aspect. And so now, this one, I want to share this because this one just came out, but it's helpful because what we have learned throughout the years that it's very difficult to get a lot of the specimen out from that. So Peter Tang, who was one of our fellow here buyers, who's now in Minnesota, and Samantha Kaku, who's now back in India, have been with us. And when they were with us, what we have done is we try to do this under air. So if you have not done this, this is a very useful technique whereby instead of infuse the eye with fluid initially that can dilute your sample, you let the air go in, and so you will do your vitrectomy under air, and therefore allow you to get more than just 2 cc's of the vitreous, a lot more, because now you have air to maintain you. You cannot do it indefinitely forever, but you will get a bit more from that. So this technique will help you with that aspect from there. And it just came out, so you can look at that and we describe exactly what setting we use and so on for that aspect from that. The communication with the lab are very, very important with that. I cannot overemphasize with that aspect from there, because the undiluted vitreous need to be sent to the various places to get the appropriate testing that was done from this process. From that we go in here. And then the diluted vitreous also can go to microbiology, can go to immunohistology, for example, in this aspect. But so we always send 2 specimens, at least the undiluted as well as the diluted from there. The cytology obviously is extremely important with this thing in there. And the reason and the cell is because not only that you need to look at carefully, but you need to understand when to deliver the specimen. There is immediate processing is needed because we don't want the cell to degrade, and therefore any use of corticosteroid and others should be avoided before this. For intraocular lymphoma, cytology is the gold standard in here. When I was a fellow at Masquerading with the hospital up there, we send our specimen. If the ocular pathologist is available, we do that. If not, we send it to the right lab over Mass General to make sure we get the right cell to be seen in here. And there's a number of cytological techniques that we use to identify this aspect. And what we definitely hope for the sake of the patient is that we definitely do not want this ugly looking cell that we see in this aspect from there, that we don't want to see. Now, the story of the interleukin 10 and 6 are definitely well known now. And this is the work of Dr. Chi Chao Chen, who used to be at the National Eye Institute. She has now retired, but one of the major work that she has done over her career, and in this case, together with the late Dr. Robert Nussenblatt, who developed the vitreous haze scale, is that they look carefully at the interleukin 10 level in this aspect. And as we have seen, interleukin 10 in the vitreous of patients with primary intraocular lymphoma elevated a lot with this aspect there. And therefore, the ratio between 10 and 6 is also elevated. So that's helped a lot. And this is one of the things that we need to know because that's what we test for. So in summary, over the last 15 minutes or so, what I have used is the situation with lymphoma as a way to work with all of us to remind us that look for and be aware of Masquerading syndrome. Certainly early diagnosis and rigorous therapy, especially with high dose methotrexate and other chemotherapy region, have definitely received a much better outcome. The early diagnosis will depend on us, the ophthalmologist, being suspicious of the diagnosis. The early diagnostic vitrectomy, again, please do not wait. The principle of management that Dr. Foster will mention next lecture will emphasize to you is that when in doubt, do a biopsy. You don't want to leave eye that keep having recurrent or persistent inflammation. And then if you're going to do a biopsy of anything, make sure you have proper handling and analysis of the specimen to help us. So finally, our opinion here would be we manage patients with intraocular lymphoma properly. Our goal, and we will get so much satisfaction is that not only we save their eye, but we also save their life as well. And I definitely have seen that throughout my career. I definitely hope that all of you will be able to do so that for the sake of our patient. And so we will finish up now with just the last two points, which is the question here. So by now, as you can see, the answer to this question will be interleukin 10, right? Because we have seen that it was 8 times in this patient. So that is the answer here. The next answer would be the clinical manifestation of intraocular lymphoma. And here we will see the aspect that they have cell and plum, a sheet of cell. They also have the Yaris lesion as in this patient. They also have this swelling. So the answer here would be D, all of the above, this aspect, and just be suspicious for this case here. So that is the end of my talk, right? In the time here, we would be glad to take any question from anyone for this aspect. I cannot see the question there. So if you have a question, please go ahead and speak up.
Dr. Wen, there's disc edema. Is that usually from mass effect or direct infiltration of the optic nerve?
So oftentimes it's due to the direct infiltration of the optic nerve with cell. And that is based on the biopsy of some of the patient with lymphoma that we see in cell.
And is that generally best addressed with radiation therapy or intrathecal?
Both, actually. So usually they like to do intrathecal chemotherapy first because for radiation therapy, they can only do it once by definition there. So therefore, they would do intrathecal first, and then if not, then they'll consider the radiation.
Thank you.
Dr. Nguyen, a similar question. For the yellow white lesions that you see, is this later? So it's an infiltrative process, but is this later in the disease, or can you see that initially?
So that's an excellent question. So by our understanding, it should be a little bit of the later, but it depends on when the patient presented to you as well too. So you may see both. I mean, in other words, you may see both the infiltrated and the cell as well, but it certainly would likely to take a little bit more to get the infiltrate, to get a lesion like this. So one would suspect it at a little bit later stage, but you can see at any of them, depend on how late or how early the patient presents to us in the clinic.
Dr. Nguyen, can I ask a quick question about the vitrectomy sampling? I haven't read the paper yet. So essentially when you're doing your core, do you switch to FAX and then you take out some of the samples while you're under air? Or is it, okay.
Yes. That's correct. So I do not prime the line, so there's no fluid the line in there. And so instead of I put in the infusion. So we do put in the infusion because we have to switch very quickly later. But so we put in everything in this aspect. We visualize the port, everything like that, and we create the 3-port. So the infusion is on. But the infusion, instead of having fluid going to it, we have air going to it. So you do your vitrectomy under air.
Including the core as well.
That's correct. You basically do core and you do periphery, but you want to stay in the core because the eye, it will eventually collapse. I mean, you cannot just do it under air completely, so it will eventually collapse. But definitely, you can get a lot more sample than you normally would.
And then you usually prefer like 27 gauge versus like 25, like the smallest gauge that you can go.
Yeah, you get this the small, but you don't want too small because you want the cell to be crushed either. So yeah, I use 27. And by the way, even though 27 is supposed to be sutureless, for this, whenever I do diagnostic vitrectomy, I for the sake of me and you sleep better, I always close it later on with suture.
And then just going back to the start of the case, the patient presented with intermediate uveitis findings before I saw the subretinal findings. So would you still get an MRI for that patient? Because like MS is still part of the differential for intermediate uveitis, but then with the subretinal lesions, I would still like go ahead, at least in Canada, we would sort of order an MRI as well.
It definitely is an appropriate thing. So it definitely would not be completely wrong if you decide to order that. I totally agree. You definitely would consider that, even though the intermediate uveitis usually doesn't present with the subretinal lesion like that. But I think that in this case, either way, whether you think along the line of MS or you think along the line of lymphoma, it would be good to have the MRI there. That would be fine.
Excellent. Thank you.
Great. So let's go ahead. I'm going to stop sharing because Dr. Foster, I believe, is on right now.